turned out to be a very big pneumothorax. Today I have seen a patient, actually a trauma patient, who had come after 3 days with pain in the back and also in the lower chest. We thought it's just a muscle pain, and it turned out to be a very big pneumothorax.
Oh, what is that case? It sounds interesting.
Yeah.
Can you please tell me more about the case?
It's actually a 60-year-old male smoker who had a fall in the washroom onto the bathtub, and he hit his back and also left lower chest region. And he presented after 3 days with pain in the back and also pain in the left lower chest.
After 3 days?
Yeah.
Okay. Let's get into more details about this case. Can you please tell me the primary survey details?
Yeah, sure. I'll do it for you. Actually, his airway is patent. He's just talking to us, and he just came walking into the ED. And his breathing is like saturations are 98 and respiratory rate is around 14. Coming to the inspection, there is no obvious bruising or any external injuries that can be seen. On palpation, there was tenderness in the left fifth rib region, and also on we couldn't percuss the patient as he is in pain. And on auscultation, there was bilateral equivalent present.
Okay, and saturation and respiratory rate, everything was on.
Yeah, they're fine.
Okay. Then let's go to circulation. What about the BP and heart rate?
They're normal. BP is around 120/80 and heart rate is around 82.
So yeah, what about the abdominal findings on inspection, palpation, percussion, and auscultation?
On abdominal inspection, there was no other external injuries. On palpation, there was tenderness in the left hypochondriac region, and rest of the other examination of the abdomen, pelvis, and long bones is absolutely fine.
Okay, disability GCS 50 on 50,
Yeah.
no neurological deficits.
No neurological deficit.
That's fine. Yeah. And pupils bilaterally equal.
Yeah, and blood sugars were fine.
Exposure temperature and any other injuries? Okay.
Temperature is normal and no other external injuries are noted.
Okay, so what about the adjuncts? Did you do any chest X-ray, pelvic X-ray?
Yeah, I've done a chest X-ray, and I think there is a small pneumothorax on the left side.
It was doubtful, or?
Yeah, it was very doubtful. Like I couldn't make it. Efast was negative.
You did proceed with the secondary survey, and then you ordered any investigations for
Yeah,
that?
I have done a CT chest and abdomen for that patient, and in CT we have got information that patient is having a very big left-sided pneumothorax, which is not consistent with his vitals.
That sounds interesting.
Yeah.
So let's discuss about the X-ray and also CT scan findings of the patient.
The X-ray of the patient looks something like this, where we can notice a pneumothorax, which is very small here, and here there is also pneumothorax. And we have done a CT because there is no obvious bony injury which is noted, which was the reason for his pain. And then the CT is here, which shows a large pneumothorax with some emphysematous changes as well.
So what did you do with the patient?
The patient presented to the minors, so we moved the patient from the minors to the resuscitation area. A trauma call was initiated, and after a primary survey, the patient is referred to surgeon for the placement of chest tube.
Yeah, I think better we discuss about pneumothorax, types of pneumothorax,
Yes.
and different treatments which we can do, so that we don't miss anything in the future.
Yeah, sure.
There are basically two types of pneumothorax based on the cause. One is, if there is a trauma, then we call it as traumatic pneumothorax. If the patient doesn't have any trauma, then we call it as spontaneous pneumothorax. So this algorithm shows management of spontaneous pneumothorax. Spontaneous pneumothorax, this is the point to highlight. If the patient is having spontaneous pneumothorax bilaterally, and if the patient is hemodynamically unstable, then you have to directly go for chest drain. This spontaneous pneumothorax, we divide it into two types. One is primary spontaneous pneumothorax and the other is secondary spontaneous pneumothorax. If the patient age is more than 50 years and has got significant smoking history or evidence of any underlying lung disease on examination or chest X-ray, we call it as secondary spontaneous pneumothorax. If the patient doesn't have any of these qualities, then we call it as primary spontaneous pneumothorax. First, let's discuss about the management of primary spontaneous pneumothorax. If you can measure the size of the pneumothorax, you have to measure here at the level of hilum the interpleural distance. If this size is more than 2 centimeters and or if the patient is breathless, then you have to go for aspiration with 16 to 18 gauge cannula. Where do we do this? Basically, it's usually we do it in the fifth intercostal space, just anterior to mid-axillary line. We can aspirate up to a maximum of 2.5 liters of the air. If you could succeed in aspirating the air, and if the size becomes less than 2 centimeters and the breathing of the patient improves, then you can consider discharging the patient and you can review the patient in OPD in 2 to 4 weeks. Or if the size is less than 2 centimeters, the pneumothorax size is less than 2 centimeters, then you can also, in primary spontaneous pneumothorax, you can consider discharging the patient and reviewing the patient in OPD in 2 to 4 weeks. So this is all about the management of primary spontaneous pneumothorax. Now let's discuss about the management of secondary spontaneous pneumothorax. Here, if the size is more than 2 centimeters or patient is breathless, you directly go for chest drain here. Unlike primary spontaneous pneumothorax, where if the size is more than 2 centimeters, you are aspirating here. But here, if the size is more than 2 centimeters, you are directly going for chest drain. So this is one of the big difference. So if the size is less than 2 centimeters, what you will do? If the size is between 1 to 2 centimeters, then you are aspirating here, unlike here. So aspirating with 16 to 18 gauge cannula and the same place in the fifth intercostal space, just anterior to mid axillary line, and the same way the limitation is 2.5 liters. So if you succeed and it becomes less than 1 centimeters, you're going to admit the patient and you have to connect it to the patient to the high flow oxygen, and you have to observe for 24 hours. And if the size is 1 to 2 centimeters, if the size is less than 1 to 2 centimeters, basically less than 1 centimeters, we admit the patient and we have to connect any high flow oxygen and we have to observe for 24 hours. So you can observe one thing here. In primary spontaneous pneumothorax, there is a chance of discharging the patient to home. But in secondary pneumothorax, irrespective of the size, whether you insert the chest drain or not, if you don't insert the chest drain also, you have to admit the patient at any cost. So if you don't insert a chest drain also, you are admitting the patient here. So irrespective of the chest drain, you are admitting the patient and connecting to high flow oxygen, and you have to observe the patient for 24 hours and you have to monitor the improvement here. So while doing Efast, if you miss certain points in doing Efast, you may miss the pneumothorax in the patient. I think that's what happened with your patient. You might have placed here, and you might have checked for pneumothorax. But when you are doing Efast, you have to consider these points R1, R2, and R3. So R1 point would be mid-clavicular line here, and you have to go diagonally like this, and you have to place your probe here, and you have to check here as well in the mid axillary line. So this covers the upper lobe of the lung, and this covers the middle lobe. So this is the R2 point. So in the mid axillary line you can check here, and you have to go diagonal like this in the R3 point, which is in the posterior axillary line. So this covers the lower lobe of the lung. So in the similar way, you have to do R1 here for the left side and R2 here and R3 laterally. So in this way, if you can do, then you won't miss pneumothorax, because patient may experience pneumothorax only in certain points. Suppose if you imagine the patient is having only pneumothorax in the upper part and he doesn't have in the lower part. So if you scan here, you will get the pneumothorax, and if you scan here, if you do M mode here, you won't get any pneumothorax or barcode sign here. So that's how we have to do, so that we don't miss any of the lung field while checking for the pneumothorax.
So in the case we discussed earlier, it could be a traumatic pneumothorax because the patient had trauma 3 days back, or it could be a secondary spontaneous pneumothorax because there were some emphysematous changes in the lungs on the CT scan and the patient age was more than 50 years. Anyway, we managed to refer the case to the surgical team, and they have managed to keep a chest drain and admitted for further management with high flow oxygen. I suspect it could be a secondary spontaneous pneumothorax. What do you guys think? Please let me know.